Good evening, everyone. How are you all? All right, so welcome to First Aid AMC MCQ free 2-week session again. So tonight we are going to finish cardiology. Not finish because we still will have ECG and palpitation chapter left, but most of the cardiology topic will be finished tonight. So I hope you guys are enjoying our session so far. So just to recapitulate what we have covered so far, you had a psychiatry review session with us, and after that we did a tips and tricks to solve questions, and then we had cardiology class 1 last just a few days ago, and then today we are doing a cardiology session 2. In between that, course students, also you have got a question solve session with our one of the mentor, and you will get another question solve session just tomorrow, right? So tomorrow you're going to have a question solve, like a random question solve discussion, just to get an idea about how the question can appear in the exam. What are the important things to look at when you are solving a questions? So that will be discussed tomorrow. So let's start with our cardiology session today. So far, you guys are getting along with us. You are enjoying the session. And any questions from our previous class? Perfect. Let's start our cardiology theory sessions too. So today we are going to start with heart failure, which is very important for your exam. So congestive cardiac failure. Now, to understand congestive cardiac failure, you need to know the how this heart actually works. So the anatomy of heart, the physiology of heart is very important to understand how this fail. And if heart fails, what are the symptoms a patient can have? Okay. So let's have a look to this video, and you'll get an idea that how actually heart works.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an
So,
even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
okay, so it gives you just a bit of idea, but there is a lot to understand that why cardiac failure happens and what are the main symptoms a patient can get. So let's discuss the pathophysiology and then we can go on. So let's say this is your heart, and definitely we know that heart has got 4 chambers, and each chamber has got valve, which is door-like structure. So we have got tricuspid valve here, and then we just change the color of it, so it will become easier for you to understand. And this is the pulmonary artery. And we have got pulmonary valve over here. After that, on the right side, we have got mitral valve. And then from here, you have got aorta. And you have got aortic valve here. Right? So that is your heart basic anatomy. So from superior vena cava, the blood will come to the right atrium. From inferior vena cava, blood will come to the right atrium. Superior vena cava will take all the upper extremity blood and it will bring to your heart. Same, all the blood from the lower extremity will be carried by inferior vena cava and it will be carried to your right atrium. From the right atrium, blood will go to the right ventricle through the tricuspid valve. And then from the right ventricle, blood will go to the pulmonary artery through the pulmonary valve. Okay? Now, through the pulmonary artery, the blood will now enter into the lungs. Into the lung, this will become oxygenated. So for all the blood, these are venous blood. So deoxygenated blood are here. So deoxygenated blood, once they enter into the lungs, it will become oxygenated. Then the oxygenated blood will be carried by the pulmonary vein. So pulmonary vein will carry the oxygenated blood into the left atrium. Okay? From left atrium, blood will go to the left ventricle through the mitral valve, and then through the aortic valve, blood will move to the aorta from your left ventricle. Right? So this is the basic function and this is how the blood will travel. So again, to recapitulate, so all the vena cava, superior and inferior vena cava, blood will take to right atrium and then it goes to the right ventricle. Through the right ventricle, it goes to the lungs through pulmonary artery, and then it becomes oxygenated. Through the pulmonary vein, oxygenated blood will be taken to the left atrium, then goes to the left ventricle, and then goes to the aorta. Okay? Now, when the heart failure happens, so heart failure can be due to a lot of conditions. Most of the time, it is due to underlying ischemic heart disease, hypertension. It could be cardiomyopathy. So lots of conditions are there which can lead to heart failure. When heart failure happens, most of the time, it is the left ventricle which gets failed. So let's say the left ventricle is not able to pump the blood as it should be. Okay? And because it can't pump the blood, so it starts to become hypertrophied. So it increases the muscle mass so that it can pump blood to your body. At some point, when it is increasing the muscle mass, it loses its elasticity. So it can't contract anymore. Okay, so that's the time heart failure happens. When it can't contract, blood starts to accumulate over left ventricle. And at some point, there will be overloaded blood in here. So it will be backflow. So blood will then get backflowed to the left atrium. At some point, left atrium will become overloaded. So then it goes through the pulmonary vein. It will go to the lungs. And that's the time patient will develop left heart, like pulmonary edema. So patient will develop pulmonary edema due to left ventricular failure. Okay. So again, blood is getting overloaded in the left ventricle. Then there is a backflow to the left atrium getting overloaded. So the blood will start to get accumulate, blood or fluid, same. It will get accumulated in the lungs. So that's the time patient develops pulmonary edema. When patient develops pulmonary edema, the main feature of it is orthopnea. So when they lie down, they get short of breath. They need to use more than one pillow when they are lying. They also can get paroxysmal nocturnal dyspnea. So in the middle of the night, they catch up for breath because at some point of the night, the lungs get full of fluid. So they get this paroxysmal nocturnal dyspnea. So these are the main feature of left heart failure. Now, at some point, when lung will get overloaded, there will be backflow to the pulmonary artery, and patient will start to develop pulmonary hypertension. Now, when pulmonary hypertension happens, there is lots of blood pressure in the pulmonary artery. So right ventricle will have difficulty to send blood through this valve because there is a lot of pressure here. So at some point, right ventricle, it will start to get hypertrophied because it needs more power to send the blood against the high pressure. So right ventricular hypertrophy will happen, and same like left heart, right ventricular hypertrophy will lead to right heart failure. Because same, it will lose its elasticity, and at some point it will not be able to push the blood into the pulmonary artery anymore. Then what will happen? There will be overload of blood in this area that will become backflow. So then right atrium will be full of blood, and at some point the vena cava, which is supposed to take blood into the heart, it can't do it anymore because already there is a lot of blood in here. So then you get, for the superior vena cava getting overloaded, you will get raised JVP. Because of inferior vena cava getting overloaded, inferior vena cava also takes blood from the portal vein or hepatic vein. So there will be hepatic congestion causing tender hepatomegaly. And also inferior vena cava carries blood from the lower extremity. Now it can't do it because it is already overloaded. Patient will develop peripheral edema. So this is the main feature of right ventricular failure or right heart failure. Okay. So most of the time it is the left heart failure. Sorry, someone's microphone is on. Please do not open your microphone. Sorry. So it is most of the time it is the left heart failure which causes the right heart failure. That's what I wanted to just show you, that if a patient gets right heart failure, most of the time the cause is left ventricular failure or left heart failure. Okay? Is it making sense for everyone that how this pathophysiology happens, how the symptoms of right and left heart failure usually comes like this? Any difficulty with understanding? Very good. Moving on to heart failure then. So a 60-year-old man presents to his primary care physician for several months of dyspnea on exertion, exercise intolerance, and lower extremity swelling. He has a past history of sarcoidosis. Physical exam shows he has JVP distension, pitting edema in the lower extremity, and the echo shows ejection fraction of 35%. So dyspnea on exertion, exercise intolerance, patient having peripheral edema, you already know that likely chance is this patient might have a heart failure. Now, let's discuss the heart failure, then I will come back to these two scenarios, that case 1 and case 2, and you will tell me what's the diagnosis. So symptoms of heart failure, because most of the heart failure patient will get fluid accumulation. Fluid can get accumulated anywhere. If it gets accumulated in the lungs, patient will develop dyspnea and orthopnea. Patient can also get a dry, irritating cough at night. They will be fatigued because of increasing fluid accumulation. Their weight will be up. Ankle edema, hepatic congestion can give abdominal discomfort as well. We know that left heart failure, the main feature is they usually get orthopnea and paroxysmal nocturnal dyspnea. That's the symptom. What about the physical examination finding? Because of pulmonary edema, these patients will always have a bibasal crepitation. So bilateral basal crepitation is a very important finding for left ventricular failure. You can also get a S3 gallop rhythm, so it is the third heart sound, which you also can get in left heart failure. Apart from that, tachycardia, tachypnea, those can be there in any kind of heart failure. For right heart failure, we already know that this patient will have elevated JVP, ankle edema, and tender hepatomegaly. Now, it's not always that the heart failure is divided into right and left heart failure. So heart failure has several subtypes. One we have already known, so right heart and left heart failure. But there is also one other kind of heart failure which is important to know to manage a patient. So there is systolic heart failure and diastolic heart failure. So all of you know that what is systole and what is diastole. Systole means when your heart needs to push blood into the aorta, the left ventricle needs to contract. This contraction of the left ventricle to push the blood into the aorta is what we call as systole. Now, if this contraction is impaired, which is causing the heart failure, that's called systolic heart failure. So systolic heart failure is the commonest heart failure, and it happens due to inadequate pumping action of the heart. Because it can't pump the blood out, and there is accumulation of blood in the left ventricle gets dilated and it contracts poorly. And ejection fraction depends on the cardiac output. Cardiac output means the amount of blood your heart can push. So if cardiac output is impaired, definitely ejection fraction will be impaired. Okay, so just remember that ejection fraction of the heart, it depends on the contractility of the heart. So in systolic heart failure, contraction is impaired, so definitely ejection fraction will be less than normal. Normal ejection fraction is above 45. Okay, less than 45 is abnormal. So most of the time in systolic heart failure, you will find that their ejection fraction is less than 45. So what is this diastolic heart failure then? Diastole means relaxation of the heart. So it's not that your heart will just contract the blood, or your heart will just contract to push the blood. It also needs time to take the blood in, right? So diastole is the time when heart gets relaxed and it allows all the blood from inferior vena cava and superior vena cava to come into the heart. So both is needed. Your heart needs contraction and relaxation. Contraction to push the blood out, and relaxation or diastole to take the blood in. So if a patient have impairment of left ventricular feeling, that means when a patient heart cannot relax properly, but it can contract properly. So contraction is fine, but it can't relax. And because it can't relax, it doesn't have enough blood to push out. So it gets heart failure in this way. Okay. So diastolic heart failure is due to impairment of the relaxation of the heart, causing impaired left ventricular feeling. But in this case, there will be preserved systolic function. So ejection fraction will be normal in this patient. Okay. And remember, if you have got a patient who is an elderly patient with hypertension, but normal heart size on a chest X-ray, coming to you with dyspnea or pulmonary edema, it is likely to be diastolic heart failure. Because in systolic heart failure, what happens? Your heart gets dilated because there is a lot of blood in here. So you get cardiomegaly on a chest X-ray. But if you don't get a cardiomegaly on a chest X-ray, but patient having pulmonary edema, then it could be diastolic heart failure. Okay? Some patient can have both systolic and diastolic failure at the same time. Now, in an easy way, systolic heart failure means there is lack of contractility of the heart, and ejection fraction will be less than 45. The most common cause of systolic heart failure is, most of the time, it is ischemic heart disease causing ischemic cardiomyopathy, and sometimes other cardiomyopathy can cause it as well. Diastolic heart failure, also known as heart failure with preserved ejection fraction, right? Because in this case, ejection fraction is normal. So heart failure with preserved ejection fraction means diastolic heart failure. It happens when the filling of ventricle is impaired, while the emptying capacity or contractility is normal. Same thing. So let's discuss about causes of heart failure. Systolic heart failure causes, you can see ischemic heart disease. Myocardial infarction is the most common cause. Approximately 2/3 of systolic heart failure is due to this ischemic heart disease or MI. And other than that, essential hypertension can be the another cause. Whereas diastolic heart failure can be found in hypertension patient, can be just a familial, obesity, ischemic heart disease, aortic stenosis, AF, any of these can cause diastolic heart failure. So far you have got an idea about right and left heart failure, systolic and diastolic heart failure. What are the investigations we need to do if a patient coming to us with symptoms of heart failure? Always remember, our initial investigation for any patient related to heart should be ECG. Even though the question gives you all the features of heart failure, and they ask you what is your next most appropriate investigation for this patient, the next is always ECG. And if they ask you what is the confirmatory test for heart failure, that is echocardiogram. So echocardiogram is the investigation of choice, or it is the confirmatory investigation to diagnose heart failure. Echocardiogram can also differentiate that is it a systolic heart failure or diastolic heart failure. How? Because it gives us the ejection fraction. If ejection fraction is normal, that's a diastolic heart failure. If it is abnormal, then it is systolic heart failure. But ECG is your first investigation and confirmatory is echo. You can also do a chest X-ray like cardiomegaly. So one of you asked cardiomegaly. We will find cardiomegaly in systolic heart failure, not in diastolic heart failure. So echo is the test of choice to confirm the diagnosis of heart failure and classify the type. There is another test called BNP, brain natriuretic peptide. Now, a lot of you think that BNP is the test to diagnose heart failure. It is not done to diagnose heart failure. It is done to assess the severity and prognosis of heart failure. Okay? So remember one thing, that BNP is not a test to diagnose heart failure. If you already diagnosed a patient with heart failure with an echocardiogram, then you can actually find out how bad is the heart failure by doing the BNP. But if, let's say, echocardiogram is not available and you need to know very fast if this patient has got heart failure or not, then definitely you can do a BNP. But if echo is available, echo is your confirmatory choice to diagnose heart failure. Okay? So what is going to be the treatment of heart failure? So heart failure step-by-step treatment will be similar like this. So first of all, you diagnosed a patient with heart failure. Your first medication of choice is ACE inhibitor or ARB. So either you go for ACE or you go for ARB. So ACE inhibitor includes perindopril, ramipril. Then ARB, you have got captopril, you have got lisinopril. Okay. So, sorry, you have got candesartan, losartan, valsartan, okay? So this ACE inhibitor or ARB will be your first choice. Now, after ACE inhibitor, what will be your next step? Your next step after ACE inhibitor will be furosemide. Especially furosemide is important if the patient has got features of congestion in the body, like there is fluid accumulation. If furosemide itself is not working, then you can add a spironolactone. When you add spironolactone, you need to monitor their potassium level because spironolactone can increase the potassium. If it's still congestion, then you can add a selective beta blocker. Now, beta blocker in heart failure, we can only add when a patient is euvolemic. That means there is no fluid accumulation is there. If there is a decompensated heart failure, like patient is actively short of breath, there is fluid accumulation in the body, we don't add beta blocker in that patient. Let's say even beta blocker is not helping, then your next option would be digoxin. So this is the step-by-step for heart failure management. Okay, so ACE inhibitor or ARB. If that doesn't work, then furosemide. Furosemide doesn't work, spironolactone. Then you can add a beta blocker like metoprolol or atenolol. Still not helping, then last option is digoxin. So this step-by-step management is very important for exam. You need to memorize this. Any question with this medication management? So I can see, so we can only use beta blocker in chronic heart failure, not in acute. That's right. Because in a decongested heart failure, patient already cannot pump blood to your aorta. If you give beta blocker, it will reduce the heart rate and contractility of the heart. So that's why in a decompensated heart failure, we don't give beta blocker. But when it is euvolemic, that means there is heart failure patient, euvolemic means there is no more congestion. That means they don't have ankle edema, they don't have pulmonary edema, no fluid accumulation. So that's euvolemic. In that time, definitely we can give beta blocker. No, for exam, you don't need to know the dose of the medication, only the name of the medication is needed. Okay, have a look that what beta blocker actually do. So chronic adrenergic activation has been implicated in the pathogenesis of heart failure. Thus, a beta adrenergic blocker are an important part of heart failure therapy. Along with ACE inhibitor, beta blocker have been demonstrated to decrease mortality, reduce hospitalization, improve functional class, and improve ejection fraction in most of the chronic heart failure patient. Start patient on beta blocker after stabilization of symptoms with diuretic and ACE inhibitor, irrespective of blood pressure status. Beta blockers such as carvedilol, metoprolol, bisoprolol have demonstrated survival benefit in trials. Okay, so that's why we add beta blocker, but definitely not in acute heart failure patient. In a stable heart failure patient, we can add that. So that was your systolic heart failure management. Okay. How about diastolic heart failure? Diastolic heart failure management depends on the finding out the cause. If a patient having severe hypertension, you have to treat the hypertension. Okay, so treating the cause is the important part. but the basic treatment is with ionotropic agents such as calcium channel blocker and beta blocker. Why? In diastolic heart failure, your heart doesn't get enough time to get relaxed. So if you can give a medication which can reduce the heart rate, that will keep the heart more time to get relaxed and get filled with blood. So you will be giving some medication in diastolic heart failure which can reduce the heart rate. So what medication reduce heart rate? Rate limiting calcium channel blocker such as verapamil or diltiazem or beta blocker. So that's your choice. We try to avoid diuretics, digoxin, or vasodilator in this patient. Why we don't like diuretics or giving vasodilators in this patient? Because if you give diuretics, the blood volume will be reduced. This patient already the heart is not getting enough blood to pump. And if you're giving diuretics and you are reducing the blood volume, then again it just can make it worse. So we try to avoid diuretics in a diastolic heart failure patient, but definitely if there is fluid accumulation, then you have to give it. Otherwise, we will avoid giving these medications to them. Sometimes question asked, what is the, which of the following medication has survival benefit in heart failure? Only 3 medication has got survival benefit in heart failure. One is ACE inhibitor, beta blocker, and spironolactone. Okay. So that's your practice tip. So you can read it in your own time. We have discussed all of this anyway. Few other things. So congestive cardiac failure, it means that there is a combination of left and right heart failure. So symptoms will be same. Pulmonary edema, you know that when there is excessive fluid accumulation in the lungs. Some of the common medications that we use in heart failure. Now, before we move on to that, I want to ask few questions. Nowadays, we just don't stop in digoxin. There is lots of other heart failure medication available. Can you tell me what are the other medication we have for these patients? Anyone? So very commonly, even before giving digoxin, we would try dapagliflozin. So yes, HGLT2 inhibitor. So dapagliflozin, which yes, commonly we use for type 2 diabetes, but that we also use for chronic heart failure patient. Not just like patient has diabetes with heart failure, for chronic heart failure, even without diabetes, we use dapagliflozin or empagliflozin. Okay, so that's even before digoxin, we would use that in Australia. So that's one. Second, yes, you are right. If a patient's ejection fraction is less than 35%, then there is an indication to use ivabradine. Okay. And ivabradine is basically it's much better than beta blocker. So it's an effective alternative to beta blocker. Okay. Now, even let's say ivabradine you have used. Yes. So Digoxin is nowadays very rarely we would use for heart failure. We would try these medications first. Dapagliflozins, we will try ivabradine if ejection fraction is less than 35. And also if ejection fraction is, let's say, even less than 30, in that case, we can use another medication. Anyone knows the name of that medication? Very, very important. Commonly we use it in Australia. What is that name? It's called sacubitril plus valsartan. So sacubitril plus valsartan. And in Australia, it is commonly known as Entresto. So this is also one of the heart failure medication. And the indication of this one is basically if the heart failure is really bad, in those cases, we would definitely use an Entresto. Okay, but again, it has to be at least less than 35% ejection fraction to use this. So these are the common medication that we would use even before using digoxin. And Entresto is a very good medication to control heart failure. So most of these heart failure patients will not require digoxin. So the step-by-step approach would be ACE inhibitor, furosemide, spironolactone. Then if it is a stable heart failure, then a beta blocker. If patients with this not getting better, we would add a dapagliflozin. If ejection fraction less than 35, we would go for ivabradine. And the other option would be to go for Entresto. Because Entresto already has got valsartan, which is a ARB. So you'll stop this ACE inhibitor or ARB from that patient's medication list. Okay, clear everyone? Now this management of heart failure is not there even in your JM. I'm talking from our Australian guideline, what we normally follow in Australia. Okay, so it is mainly from therapeutic guideline, you can say, that we follow, but it's even not in John Motter. They have written that. So the last point was this Entresto already has valsartan, which is a ARB. So your initial medication was ACE inhibitor. So if you start Entresto, you will stop ACE inhibitor or ARB from the patient's medication list because already you are giving it in here. Okay. All good, guys? Moving on. So some of the commonly used diuretics in heart failure. So as you can see that we use a lot of diuretics in a heart failure patient. The common diuretics that we use is loop diuretic or furosemide. And sometimes as part of hypertension, we can use thiazide diuretics. So thiazide diuretics, the main side effect, so in exam, pharmacology is not like, it doesn't come as a pharmacology, but a lot of side effects of common medication comes in your exam. So all the common medication side effect you should know, because drug-drug interaction, drug side effect is a very, very important topic for exam. So thiazide diuretics causes hyponatremia, hypokalemia, but it causes hypercalcemia. It can also increase the uric acid, causing gout. And also it can increase glucose intolerance. So it's not a very good medication for a diabetes patient, not a very good medication for a gout patient. Indapamide has similar kind of complications like thiazide diuretics. Then there is loop diuretics, which is basically furosemide and bumetanide. These two we use in Australia. So complications are everything gets hypo. So hyponatremia, hypokalemia, hypocalcemia. They can get hyperuricemia. Furosemide can cause nephrotoxicity and ototoxicity. So ototoxicity, that means toxicity of the inner ear, and also it can cause nephrotoxicity. Okay. Then you have got potassium-sparing diuretics, which is a spironolactone. So hyperkalemia and gynecomastia is the main side effect of them. So very important is gynecomastia, which is a common complication of spironolactone. Okay. So all of these diuretics lower down the potassium except the spironolactone. Next, digoxin. Why don't we use digoxin too much anymore? There is a reason behind it, because it has a lot of side effect and it's not worth it, because we have got a lot of good medications in the market. But it's good to know about how digoxin works. It's good to know how, like, what are the complications of it and everything. So we'll discuss a little bit. So let's get a basic idea. So you know that you have got, so every cell has got a sodium potassium pump. Okay. And what will happen with this sodium potassium pump? This sodium potassium pump is needed for your sodium will go in. Sorry, the sodium will go out and potassium will go into the cell. Okay. Now the problem, what happens is that digoxin or digitalis, it inhibits this sodium potassium pump. So basically what will happen, sodium is supposed to go out of the cell, and through this pump, potassium is supposed to come inside the cell. Now, if digoxin inhibits this pump, sodium cannot go out, potassium cannot come in. So there is intracellular sodium. And when there is increased sodium in the cell, it also decreases the exchange of calcium. So if there is more sodium inside the cell, calcium also cannot go out, which means there is more and more calcium in the cell. So when there is more and more calcium in the cell, calcium causes increased contractility. Okay, so calcium will cause increased contractility of the cardiac muscle. So this is how digoxin works. Okay, so digoxin mainly inhibit the sodium potassium pump, causes increasing of intracellular calcium, which causes increased cardiac contractility. So that's why it is good medication for systolic heart failure, because it increases the cardiac contractility. Okay, so now you know how this works, right? The problem is that sometimes patient who has got electrolyte imbalance, they can have digoxin toxicity. How? Let's have a look. So am I making this very confused? Are you guys understanding me? Like, I know this is a lot to take in, but is it making sense? Okay, so that's good. Now let's say someone who has got hypokalemia. So if a patient has got low potassium in their blood, what happens is that digoxin compete with the potassium to get inside the cell. Again, digoxin will compete with the potassium to get inside the cell. If there is less potassium, digoxin is now more strong. So more and more digoxin will go inside the cell and it can cause digoxin toxicity. So that's why hypokalemia can cause digoxin toxicity. So that's what is written in here. Hypokalemia results in toxicity. Okay. Other than that, there are other conditions which can also cause digoxin toxicity, like if a patient has got renal failure, because digoxin is excreted by kidney. So if kidney failure is there, then there will be toxicity. Electrolyte disturbance such as hypokalemia, hypomagnesemia, hypercalcemia. So thyroid disease like hypothyroidism, this can cause digoxin toxicity. So if a digoxin toxicity happens, what will be the symptom? The most common symptom is nausea, vomiting. Apart from that, gynecomastia, blurred vision. They can also see this yellow halo around the objects. And digoxin toxicity can cause almost any kind of arrhythmia. But the most common arrhythmia is paroxysmal atrial tachycardia and premature ventricular complex. So almost any kind of arrhythmia it can cause, but the most common is paroxysmal atrial tachycardia and premature ventricular complex, PVC. So if a patient is on digoxin coming to you with a sudden nausea, vomiting, blurry vision, yellow halos around the objects, then you think that it is most likely digoxin toxicity. Sometimes even patient is having digoxin toxicity, the blood digoxin level can be normal. So just because digoxin level is normal in the blood doesn't rule out digoxin toxicity. So sometimes symptom and sign is more important than the blood test. So if there is sign and symptom, then you have to stop the drug. And after stopping the drug, most of the time the symptom will get better. If it is a severe symptom, then there is an antidote for digoxin that's called Digibind. What is called? Digibind. So this can be given if it is acute overdose or patient having severe symptom. There is one other thing that also sometime will be used in a patient with systolic heart failure. So if a patient has got ischemic dilated cardiomyopathy, like patient has got ischemic heart disease and it has caused ischemic cardiomyopathy, because in case of ischemic cardiomyopathy, sudden death is very common and it mainly happens due to cardiac arrest or arrhythmia. You can give a device which is called automatic implantable cardioverter defibrillator, AICD. So if a patient goes to cardiac arrest, this device will automatically shock the patient. Okay. So this is only given if a patient has got, you have tried all the medication, still there is a persistent ejection fraction less than 35. Okay. So in that patient, this cardioverter defibrillator is indicated. Next, pulmonary edema. So we know that pulmonary edema means that patient has got fluid in the lung and they will come to you sometimes with sudden onset of acute shortness of breath. And you will know that this patient might be a known heart failure patient. This is a medical emergency because oxygen saturation can go severely low in this patient because of impaired gas exchange causing respiratory failure. So you will get bibasilar capitation, and if you do the chest X-ray, you will get this kind of bat wing appearance. So you can see that definitely the heart has got enlarged in size, and you can see this batwing appearance, which means bilateral opacity around the heart, which is called batwing appearance. If you get that, that's pulmonary edema. So for pulmonary edema, your treatment will be, first of all, sit the patient upright, so propped up position. Start the patient with oxygen. Then diuretics is very important for this patient. So your first medication should be diuretic, like furosemide, to reduce the excessive fluid from the lung. This kind of patient can also get benefited from morphine. You can give nitroglycerin, digoxin, any of those can be given, but diuretic is the main treatment of choice. Okay, so that's all about heart failure, guys. Any questions so far? Are you with me? You're okay? So AICD is given if you have tried all the heart failure medication and still patients having a ejection fraction persistently below 35%, then you will go for that cardioverter defibrillator. And you guys want to know the summary of heart failure medications going back. So summary will be, you start with the ACE inhibitor or ARB. So any of those, ramipril, perindopril, captopril, losartan, valsartan, any of those, plus furosemide. If that doesn't work, then you add a spironolactone. Doesn't work, you have a selective beta blocker like carvedilol, bisoprolol. You can use this only if a patient is a stable heart failure. Not helping, you can use dapagliflozin. Now, most of these patients who doesn't get better with dapagliflozin, their ejection fraction will be less than 35. If it is less than 35, you can use ivabradine and you can use Entresto. Okay, the most effective heart failure medication at the moment is Entresto. Which one is less than 30%? Entresto. Nowadays, digoxin is not the good option to choose. So we would not choose digoxin in these patients because we have a lot of better medication to choose. So dapagliflozin, we will choose instead of digoxin. Now, most of the time, DAPA is used as part of like a initial heart failure medication. So we add ACE inhibitor, we use a beta blocker if patient is stable, and we add a dapagliflozin. These three medication we start for every stable heart failure patient. When they get congested, we add furosemide and spironolactone. Okay, so that's usually how it occurs in real life, but a step-by-step approach is how it is written in here. What surgical indication, Dr. Imran? We didn't talk about any surgical procedure for heart failure. Empagliflozin is not commonly used for heart failure. It's mainly dapagliflozin. Ivabradine is also less than 35. That's right. Ivabradine will not be used above 35. And pulmonary edema. Okay, so pulmonary edema means there is fluid accumulation in the lungs. And when there is fluid accumulation in the lung, there will be definitely the patient will get orthopnea, which means when they lie down, their symptom of shortness of breath will get worse. And if you do a chest x-ray, you will get this kind of bat wing appearance, which means that there is, see this opacity over here and here. This interstitial opacity is very common in a pulmonary edema patient. Sometimes it might not be that much worse. Sometimes it can be just like this. But the cardiomegaly, the symptom of heart failure and bit of bilateral opacity like this, that's pulmonary edema. For pulmonary edema, your first management is propped up the patient. So sit up the patient upright, start oxygen, and then give diuretics. Okay. And for heart failure, dapagliflozin, like there is a lot of complicated pathophysiology is there, which I don't need to go through for AMC MCQ exam. But just remember, dapagliflozin means it reduces the amount of work. So the heart needs to pump blood, and it needs more and more strain to pump the blood. So dapagliflozin basically reduces this strain on the heart. Okay, so that's how it usually improves the heart failure. But there is a lot of like complicated pathophysiology behind it, which we don't need to go through. Okay, so now heart failure is done. If you know up to this, you will be fine. Okay, moving on to valvular heart disease. For dapagliflozin, there is no specific indication of heart ejection fraction. You can use it initially. When you diagnose a patient with heart failure, you can start DAPA. So come back, guys. Come back from DAPA and EMPA and all other things. So valvular heart disease. So valvular heart disease is important for exam. In valvular heart disease, the only thing that comes in exam is they give you a murmur and they ask you what type of valvular heart disease this patient has got. Okay, so, oh yes, that's right. I forgot to give you those two questions. I don't think we need to go back because you will know now these two questions answered. So read the first case and second case and tell me what's your diagnosis for these two. Excuse me. Okay, case 1, systolic heart failure. So let's see, 62-year-old man, hypertension, dyslipidemia, coming with dyspnea, and lower extremity edema for 2 months. There is raised JVP, S3 gallop, apical impulse displaced. Chest X-ray shows enlarged cardiac silhouette. Echo shows a dilated left ventricle with the ejection fraction 35. So very easy to know that it is definitely a systolic heart failure because there is cardiomegaly, there is low ejection fraction. So good. 57-year-old man with history of multiple myeloma comes with dyspnea and lower extremity edema. There is raised JVP, S4 gallop rhythm, S4 rhythm. Then there is apical impulse non-displaced. Chest X-ray shows normal cardiac shadow. Echo shows ejection fraction of 65. So this one also easy for you. This is a diastolic heart failure because you can see there is no cardiomegaly and ejection fraction is normal. Okay, so very good. So you do understand heart failure pretty well then. Let's move on to valvular heart disease. Valvular heart disease, as I say, that you have got tricuspid valve, pulmonary valve, mitral valve, aortic valve. Now these valves, the main question that comes in exam is just knowing the murmur. There is no easiest way to remember it. You have to memorize those murmur. Okay, but I can give you a bit of idea. So first of all, have a look about the positioning of the murmur. Oh, my screen is already shared. I don't know what's happening with you, Dr. Khan. I'm sharing the screen. Maybe you should just rejoin the class. The screen is already shared. Okay. All right. So have a look over here. So let's say this is second intercostal space, third, fourth, fifth, sixth. And that's the heart. Okay. We are talking about 4 valves in the heart. The positioning of the heart valve is important because that will help you in the exam a lot. So mitral valve is at the apex. So this is the apex of the heart, which is most of the time at the 5th intercostal space along the mid-clavicular line. So that's mitral valve. Then at around left 4th intercostal space over here, you have got tricuspid valve. Now, this will be a little bit tricky. So you know that how aorta comes? So aorta comes like this. So aortic stenosis murmur will be hard on the, so this is right, this is left. So aortic stenosis murmur will be hard on the right second intercostal space. Okay? But aortic regurgitation murmur, it's best hard on the left fourth intercostal space. Again, aortic stenosis murmur is best hard on the right second intercostal space, whereas aortic regurgitation murmur best hard on the left fourth intercostal space. Okay? And you know that pulmonary, sorry, let's just change it. the pulmonary artery goes like this towards the left. So pulmonary valve murmur is best heard on the left second intercostal space. Okay, now giving you the summary again. So mitral valve best heard on the left fifth intercostal space. That's the apex of the heart. So for mitral valve, you have got mitral stenosis or mitral regurgitation. Then we have got aortic tricuspid valve, which is best heard on the left fourth intercostal space. Same, tricuspid valve has tricuspid stenosis or regurgitation. Tricuspid doesn't come in exam, so don't get bothered about this. Then you have got aortic valve murmur. Aortic stenosis murmur best heard on the right second intercostal space. Aortic regurgitation murmur best heard on the left fourth intercostal space. And then you have got pulmonary valve murmur, so pulmonary stenosis and regurgitation best heard on the left second intercostal space. So don't think that because pulmonary, we know it is on the right, it is connected to the right heart. So a lot of candidate gets confused that why it is best heard on the left second. So this is why, because it just goes like this. That's why it is best heard on the left side. And as the aorta goes around like this, that's why it is best heard on the right side. Okay? This is making sense for everyone, like the positioning of the heart valve murmurs? So both PSPR at the left second intercostal space. So yes, most of the time your pulmonary valve murmur is at the left side. Again, pulmonary murmur is not important for exam. For exam, only important murmur is mitral and aortic. Now we are going to discuss about the murmur for mitral and aortic because that comes in exam. So I always remember one murmur and I can easily find out the other three. How? So mitral stenosis murmur is mid-diastolic murmur, and definitely it is best heard at the cardiac apex. Okay, so at left fifth intercostal space. So it is mid-diastolic murmur in the or MS or mitral stenosis. For the purpose of remembering, think that the opposite of mitral valve is aorta and opposite of stenosis is regurgitation. It's just to keep it memorized, okay, not for anything else. So what is the opposite of mitral? Aortic. And what is the opposite of stenosis? Regurgitation. So we have got aortic regurgitation, which also is a diastolic murmur. But what kind of diastolic murmur? Early diastolic murmur. Okay? So this is how you can easily remember the diastolic murmur. Now, the opposite of these two are systolic murmurs. So opposite of MS, that means what is the left out? So left out from MS is MR, and left out from aortic regurgitation is AS. Right? Both of these are systolic murmur. But aortic stenosis is ejection systolic murmur, whereas mitral regurgitation is a pansystolic murmur. Okay? Now, this is exactly how I remember because I can't memorize this. And if I get confused in any exam, I can easily find it out. It's very easy to find out because in exam, the options will be a lot of options. You can easily come to at least two options in the exam. using this formula. So all you need to know the positioning of the heart valve and type of the murmur. And if you just remember this, you can easily find out the others. Okay? Is it understandable for everyone? Did you guys get it? Do I need to repeat? Okay. So if we're repeating this, so first of all, just remember what is mitral stenosis murmur. Mitral stenosis murmur is mid-diastolic murmur. All you need to remember is this. And just think, for mitral, opposite is aortic, and this opposite of stenosis is regurgitation. So you have got aortic regurgitation. That is also diastolic murmur. So this two is diastolic murmur. Mitral stenosis is mid-diastolic, so you can even remember by M for M. And aortic regurgitation is early diastolic murmur. Definitely you need to memorize a little bit, but it's easier in this way. So you know that for mitral valve, there is two kind of murmur. One is mitral stenosis murmur and another is mitral regurgitation murmur. Same aortic, we have aortic regurgitation and aortic stenosis. So these are the two left out. For these two left out, these two will be systolic murmur. And mitral regurgitation is pansystolic murmur, whereas aortic stenosis is ejection systolic murmur. So this part you have to memorize. And these two murmur, they radiates. So mitral regurgitation murmur radiates to axilla, and aortic stenosis murmur radiates to the neck or carotid. These two murmur does not radiate. All right. So try to remember what we talked about, because these are very important for exam. Okay. And in here, in the note, I have given all the murmur types and everything. Definitely you can go through that in your own time. If you go to Med Bullets, so Med Bullets is another guideline. So you can also go to the Med Bullets and also just learn a little bit more about the heart murmur if you want. But as long as you remember the mitral and aortic murmur, that's usually important for exam. All right, now we are going to take a 5-minute break. And after the break, we will come back again and we will start with cardiomyopathies. All right, everyone, let's start again. Now we are going to discuss few things which is not super important for exam, but it's good to know. So cardiomyopathy. So cardiomyopathy means that the muscle of the heart is abnormal. There are three kinds of cardiomyopathy. One is this dilated cardiomyopathy, then there is hypertrophic obstructive cardiomyopathy, and then there is restrictive cardiomyopathy. The common one which comes in exam is HOCM or HOOCM. We will discuss that. Now, dilated cardiomyopathy, it is characterized by diminished myocardial contractility. So in dilated cardiomyopathy, the heart gets dilated and it can't contract. So what kind of heart failure it will be, guys? So if the heart loses its contractility and it gets dilated, what kind of heart failure this patient will have? Systolic heart failure. Very good. So this patient also gets all the sign and symptom of systolic heart failure. The most common cause of dilated cardiomyopathy is idiopathic. So no one knows. But patients who are alcoholic, sometimes it could be related to some toxin, medication. So a lot of causes are there. So this kind of patient most of the time will present with heart failure. So all the symptoms of heart failure, like a congestive cardiac failure symptoms will be there. And because it gives systolic heart failure, ejection fraction will be low in this patient. Okay. And the treatment will be same like the systolic heart failure symptoms. So you will treat these patients with same ACE inhibitors, furosemide, so all the same treatment like systolic heart failure. So for this kind of patient, if their ejection fraction is less than 35 and they have a ischemic dilated cardiomyopathy, they fulfill the criteria to get this AICD, which is that automated implanted cardioverter defibrillator. So this implantable cardioverter or defibrillator is usually the group of patient who gets this is who get this ejection fraction less than 35 and they have got this ischemic dilated cardiomyopathy. You can easily see that normal heart looks like this, and for dilated cardiomyopathy, how much dilated it is. Next is HOOCM or hypertrophic obstructive cardiomyopathy. This is commonly asked in exam. So in HOCM, what happens is that you can see that this is the septum, right? So interventricular septum, which separate the right and left ventricle. In HOCM, this septum gets hypertrophied. You can see how much big it is. So because it gets that much bigger and hypertrophied, there is not much of a space in the left heart to fill with blood. So the problem is in HOCM is that it can't get enough filling with blood, or it can't get that much dilated. So if it can't get dilated, what kind of heart failure you will get in this patient? You will get diastolic heart failure. So as a result of the hypertrophy, left ventricular compliance is reduced. That's why diastolic dysfunction is characteristic in this patient. But because you can see that there is only a small space left for the blood to come into the left ventricle, and the muscle is very strong. So with this muscle, the heart contractility is very high. So sometimes even the ejection fraction becomes 80 to 90% in this patient because of the hypertrophied muscle. Okay. So that's usually what happens in HOCM patient. So HOCM, in more than 60% cases, it is autosomal dominant. So there is a hereditary pattern in this patient. The distinctive hallmark is unexplained myocardial hypertrophy, especially thickening of the interventricular septum. Because of the septum and the heart becomes very hypertrophied, the heart becomes hypercontractile and systole occur with striking rapidity. Because in these patients, systole will be very rapid and strong. So ejection fractions are often 80 to 90%. Okay. So symptoms will be as if the patient having a heart failure. So dyspnea, they can get syncope, palpitations. Few other things characteristic for this patient is a beefy carotid pulse, S4 gallop rhythm, and also a large jugular airway. Now, these are not important. You can just remember that this patient can get beefy carotid pulse and all of this. Sometimes in the family, a sudden cardiac death can be a presentation. Many times we see that young patient suddenly gets a blackout or sudden loss of consciousness, which is syncope. And there is a family history of sudden cardiac death in the family. So always, if a young patient coming to you with syncopal attack, especially sudden syncope, then and there is a family history of sudden cardiac death, then definitely we will consider the possibility of a HOCM. So if we consider HOCM, our initial investigation is a ECG, and in the ECG you can get left ventricular hypertrophy, and the confirmatory test is echocardiogram. In the echocardiogram, it will confirm the hypertrophied interventricular septum. But many times we have seen that if you do a resting echo, it might be normal. So if you are quite suspicious about HOCM and you have done a resting echo, there is nothing abnormal. To confirm it or to be totally sure, you can do a stress echocardiogram. And the stress echo is the confirmatory test for HOCM. So a lot of time questions are asked. Now, the treatment will be same like any diastolic heart failure symptoms. So for diastolic heart failure, we give beta blocker and calcium channel blocker. So for this patient, same, you'll be giving this same treatment. Same for diastolic heart failure, we avoid diuretics, we avoid vasodilator like nitrate, we avoid digoxin. So for HOCM patient, also it is better to avoid this medication. So that's how come. The other cardiomyopathy is restrictive cardiomyopathy. It is the least common cardiomyopathy, but the treatment is like there is no treatment for it, okay, apart from a heart transplantation. So restrictive cardiomyopathy, what happens is that your heart needs elasticity to contract and to relax. But if your heart wall or ventricular wall become rigid, there's a time it becomes restrictive cardiomyopathy. So many times sarcoidosis, amyloidosis, hemochromatosis, these conditions can cause this rigidity of the ventricular muscle. So you can see that if the heart muscle becomes stiff and rigid, definitely it can't do anything. So for these patients, both systolic and diastolic heart failure can happen. Because it can't do systole, it can't do diastole. Okay? So symptoms will be similar like heart failure symptom, and echo is the diagnostic test. You will start with the ECG and then echo will be the diagnostic test. There is no medical treatment, and the only treatment is heart transplantation, as I said. Okay, so these are the three cardiomyopathy, but the common one which is asked in the exam is HOCM. Any question, guys? Are you with me? Ischemic heart disease most of the time causes dilated cardiomyopathy. Good. Next, acute pericarditis. In our first class of cardiology, we did discuss a bit of acute pericarditis. So pericarditis means inflammation of the outer layer of the heart, which is pericardium. Most of the time, they give you a history of a viral infection before this happens. Apart from viral pericarditis, patient who develops connective tissue disease like SLE or lupus, they can also get pericarditis. Patient who gets like uremia, they can get pericarditis, like renal failure related ones. Sometimes even inflammation, neoplasm can cause it. But most commonly it is related to viral infection. So this patient will come to you with a retroesternal or left-sided chest pain, which will be sharp, knife-like, stabbing chest pain. The pain will get better with leaning forward and worse with lying down. Okay? It can get also worse with taking a deep breath or inspiration. If you auscultate their heart, you can get a pericardial rub. So kind of a noisy sound on the heart. And then if you do a ECG, you will get a widespread ST elevation in all the leads. So that's usually confirm the diagnosis when you get a widespread ST elevation in almost all the leads. That's pericarditis. So most of the time you don't need to do anything for this patient. All you need to do is just rest and anti-inflammatories. So NSAID aspirin is the usual treatment of choice. Sometimes we can give a steroid or even colchicine. Okay. So that's your pericarditis. Next, pericardial effusion. Sometimes patient can develop fluid accumulation around their pericardium causing pericardial effusion. Just like pleural effusion, patient can have pericardial effusion as well. So the fluid that develops around the heart can be transudative, can be exudative. Transudatives are common in heart failure. Okay. If there is serosanguinous pericardial fluid, can be found in tuberculosis or neoplastic disease. Now, this is not important for exam. The important is when there is more and more fluid accumulated around the heart or in the pericardial space. So let's see, this is the heart and that's your pericardium, right? When more and more fluid is around the heart, sometimes it can get that bad that it can start to compress the heart. So when it starts to compress the heart cannot relax and it impairs the cardiac feeling. And that's time we call this as cardiac tamponade. So cardiac tamponade is a life-threatening condition in which pericardial effusion has developed so rapidly or has become so large that it's now compressing the heart. And patient who develops cardiac tamponade, they will be short of breath, fatigue, and orthopnea will be there. You can get neck vein distension. The most important thing that we get is called Beck's triad. So in patients with acute tamponade, they will have hypotension, distended neck vein, so raised JVP, and a muffled heart sound or decreased heart sound. So if you have got a patient, many times tamponade can happen even after a trauma, like a motor vehicle accident. So if you have got a patient who fulfills all the criteria for tamponade, like low blood pressure, there is distended neck veins, there is muffled heart sound, and patient is quite short of breath, what will you do? Your diagnosis depends on a bedside echocardiogram. So you will do an echocardiogram and echo will be able to confirm the diagnosis. And you will need to immediately do a pericardiocentesis with a wide bore large cannula. So pericardiocentesis is the treatment of choice. Okay. Sometimes in pericardial effusion, if you do a X-ray, you can get this kind of water bottle appearance of the heart. That's because of lot of fluid around the heart. Okay. So that's cardiac tamponade. Very important to know because sometimes they give it in surgical questions. Okay. Next, constrictive pericarditis. Not very important, but just remember constrictive pericarditis means the pericardium becomes very thick. Now, this is the heart, and the outer covering of the heart is pericardium. Heart needs to relax. And if heart needs to relax, pericardium also needs to relax. But what if pericardium gets rigid and stiff? Then the same thing will happen. Heart cannot relax properly. So this kind of patient, again, the problem will be abnormal diastolic feeling. So because the pericardium has got reduced elasticity or reduced distensibility. Okay. Many times it can be related to post-viral infection, idiopathic, after a open heart surgery, this can happen. So symptoms will be same like heart failure, so dyspnea, orthopnea. They can get ascites, edema, so all the heart failure symptoms can be there. But if you do a chest X-ray on this patient, you will get this calcification around the heart. Can you appreciate this calcification around the heart? This is called X on string appearance. So this X on string appearance is very commonly we find in a constrictive pericarditis patient. You will never get this kind of like calcium marking or white marking around the heart. When you get it, definitely it is a constrictive pericarditis. Okay. Management depends on the cause. So treat the cause, then this will be treated. And if there is symptoms of heart failure, you'll have to treat the heart failure symptoms. Okay. So that's all about your cardiomyopathy, pericarditis, pericardial effusion, tamponade, constrictive pericarditis. So that's all about it. Okay. Now we are going to another chapter from John Murtagh, which is hypertension. This is in your JM 8th edition, that's chapter 77. Now, hypertension is a very common thing, right? So, lot of, like we know, millions of people has high blood pressure, but in your country, anyone coming to you with a high blood pressure, you just start them with medication. That's not the case in Australia. You have to be very careful when you start antihypertensive. It's not indicated for everyone. There is a step-by-step approach that we follow. Okay, so that's important to know. So first of all, it is recommended to check the blood pressure every 2 yearly for anyone above 18. Optimal blood pressure is systolic less than 120 and diastolic less than 80. But you can tolerate systolic up to 139 and diastolic up to 90. So that's called high normal. Anything above 140 by 90 is hypertension. Okay? And we can also divide it into mild, moderate, and severe based on the systolic and diastolic heart failure. There are lots of causes of hypertension, but most of the time there is no cause. So 90 to 95% cases, it is essential or primary hypertension. So there is no cause of high blood pressure, it just happens. And then there is 5 to 10%, there's a lot of causes. So kidney related, glomerulonephritis, renal artery stenosis, Endocrine related like Cushing syndrome, Conn's syndrome, pheochromocytoma, even oral contraceptive can cause it. Coarctation of aorta, some medications such as anti-inflammatory and steroid can increase the blood pressure. Even pregnancy can increase blood pressure. So these are the secondary causes. Some of the clinical feature will suggest a likelihood of secondary hypertension, such as if you get a patient who has resistant hypertension, so you have tried maximum doses of 2 antihypertensive, still blood pressure is very high. And then you have auscultated the renal artery and you have got a renal artery bruit. So having a renal artery bruit indicates renal artery stenosis. Okay. If you have got a patient who is having proteinuria and RBC cast in the urine with hematuria, could be glomerulonephritis causing the hypertension. Sometimes patient can have bilateral kidney mass, that's polycystic kidney disease. Radioradial delay, radiofemoral delay can be found in coarctation of aorta. Okay, so a lot of things are there which we look for if we are thinking about a secondary hypertension. There is two other terms. One is called malignant hypertension and another is called refractory hypertension. Malignant hypertension is when diastolic blood pressure is more than 120 and patient has got retinopathy or nephropathy. So if there is vision problem or kidney problem along with diastolic blood pressure above 120, you would be concerned about a malignant hypertension. What is refractory hypertension? As I said, if you have tried maximum dose of 2 drugs for 3 to 4 months and still the blood pressure is high, that's refractory hypertension. We don't look for secondary hypertension unless a patient has got refractory hypertension. Most of the time, we think that it is primary hypertension. But if we try 2 medication maximum dose, still blood pressure not going anywhere, that's the time you will try to look for any secondary cause. Renal artery stenosis commonly asked in exam. The most of the time it is caused by atherosclerosis in elderly patient or middle-aged patient. Whereas if it is a young female coming to you with a feature of renal artery stenosis, you would think of a condition called fibromuscular dysplasia. So renal artery stenosis, only time we consider is if it is a refractory hypertension, if we get a renal bruit. Sometimes this patient can have proteinuria, even sometimes hematuria. Not common though, but you can get it. How to confirm renal artery stenosis? You will have to send the patient for a duplex ultrasound of the renal artery. Very important, comes in exam. If a patient has got renal artery stenosis, if it is a unilateral renal artery stenosis, the treatment of choice for hypertension, if you need to start medication, it will be ACE inhibitor or ARB. If it is a bilateral renal artery stenosis, you can't use ACE inhibitor or ARB, that's contraindicated. For that patient, calcium channel blocker will be the best idea. That comes in exam. So if it is a unilateral renal artery stenosis, your choice of antihypertensive is ACE inhibitor or ARB. If it is bilateral renal artery stenosis, then CCB. Now, just because a patient has high blood pressure just once in your office doesn't make that patient hypertensive. To diagnose hypertension, so diagnosis should not be made on the basis of a single visit. Initial BP reading should be confirmed on at least 2 other visits within a space of 3 months. And within a space of 3 months, if the average blood pressure is above 140/90, then you can diagnose a patient with hypertension. Okay? Follow-up criteria. So how we normally follow up in a patient with hypertension depends on the grade or stage of hypertension. So if a patient has got, let's say, high normal hypertension, then or high normal blood pressure, we will check the blood pressure at least every year, and we will ask the patient to start some lifestyle modification. Once it becomes hypertension, like a grade 1, so grade 1 hypertension, you will need to confirm, because you can't diagnose in a single visit, so you'll need to confirm it within the next 2 months and start lifestyle modification from the day 1. So for grade 1, you are not going to start medication. Okay? For grade 2, so systolic up to 179 and diastolic up to 109, you will need to evaluate the patient within 1 month. So within 1 month, you will confirm if the patient has got hypertension. You will start the patient with lifestyle modification. If it is grade 3, you have to evaluate the patient within a week, or you can start the patient with antihypertensive for this case from day 1. Okay, so this is the only time you can start antihypertensive on a single visit. So if mild hypertension is found, observation with repeated measurement over 3 to 6 months should be followed before beginning the treatment. Okay. Initial diastolic reading above 115, particularly if a patient has got target organ damage like retinopathy, nephropathy, then they will need an immediate drug treatment. So if diastolic above 115 plus they have got some organ damage like kidney failure, then you can start treatment immediately. There is a test that we do called ambulatory 24-hour blood pressure monitor. So there are some patients whose home blood pressure is normal. So in a relaxed space, they are very good. Their blood pressure is completely normal. But when they come to your GP clinic, their blood pressure spikes. That is called white coat hypertension. Now, how do we confirm it? Because we can't confirm it if we don't know how is the home blood pressure looking. So when there is a marked variability of office blood pressure and home blood pressure, or there is unusual variability between multiple GP visit blood pressure, there is resistant to drug treatment. In this situation, you can order a 24-hour ambulatory blood pressure monitoring. So what will happen? Patient will do his usual work, and a blood pressure device will be attached to the patient's arm, and throughout the 24-hour, it will record the patient's blood pressure. And at the end, it will give an average blood pressure for that day. So in that way, you can get a very good reading that this patient actually has got high blood pressure or not. Okay? Management. So if average diastolic blood pressure is between 90 to 100, and there is no evidence of target organ damage, non-pharmacological therapy is indicated for 3 months. And non-pharmacological treatment means that weight reduction, even if a patient can reduce 1 kilo body weight, their blood pressure will drop by 2.5 millimeters systolic. So this is the most important part to reduce the blood pressure. Then reduction of excess alcohol, reduction of excess salt in the diet. Now this chart is very important for your exam. Any patient who has high blood pressure on several occasions, our main step is lifestyle advice. At the same point, we also assess their 5-yearly cardiovascular risk assessment. Remember that chart we have shown in our question solved class? So when you do the CVD risk assessment, it gives you, is it a low risk patient, Is it a moderate risk or high risk? If it is a low risk patient, you can maintain lifestyle change for at least 6 to 12 months. So for low risk patient, grade 1 or grade 2 hypertension, you can just continue lifestyle for even 6 to 12 months. Okay? For moderate risk patient, lifestyle for 3 to 6 months, and if still after 3 to 6 months blood pressure persistently high, you can start treatment. For high risk patient, and especially like they are high risk and they're having a grade 3 hypertension, then definitely you will have to start treatment immediately. Okay, so grade 1 and 2, most of the time if they don't have high risk, you can just like continue lifestyle for at least 6 months. For high risk patient on CVD chart and grade 3 hypertension, definitely you can start treatment on that day. So what to start? What's the first line medication? You can choose any of them. So you can either choose a ACE inhibitor or ARB, or a calcium channel blocker, or a thiazide diuretic. Any of them can be your first line medication. After 3 months, if it is not getting better, then you can add. So you can add a ACE inhibitor with a calcium channel blocker. You can add ACE with a thiazide diuretics, ACE with a beta blocker. Still not helping? After 3 months, you can add all of them together. Still not helping? You can use a spironolactone or seek a specialist advice. Okay, clear? So you can choose ACE inhibitor, calcium channel blocker, or low dose thiazide diuretics. Now, ACE inhibitor is especially we start after 55, but it can be started in any age group. There is no problem. And organ damage can happen at any stage. Not only just severe, even in moderate stage, patient can have organ damage. Okay. So that's the step-by-step approach of medication in a hypertensive patient. Clear, everyone? But it's a good idea not to combine a beta blocker with a rate limiting calcium channel blocker, because beta blocker reduce heart rate, and if you also add verapamil, it also reduce heart rate, and it can precipitate heart block or heart failure. We also don't combine ACE inhibitor and ARB because they're usually the same thing, because ACE inhibitor and ARB causes hyperkalemia. You have to be careful before you add a spironolactone with this. Okay, because ACE causes hyperkalemia, spironolactone causes hyperkalemia. So you will have, if you really need to combine these two, then you will have to monitor their potassium quite frequently. Okay. What is hypertensive emergency? Hypertensive emergency means that when a patient has got blood pressure more than 180 by 110, along with that, they have got hypertensive emergency feature like hypertensive encephalopathy, stroke, heart failure, dissection of the aorta, and eclampsia. These are all hypertensive emergencies, and this patient needs to go to the emergency department for further treatment. You can't reduce the blood pressure heavily or rapidly in this patient. Your aim will be to reduce the blood pressure by no more than 25% within the first 2 hours. And you will just lower it down up to 160 by 100. So you don't give a lot of blood pressure medication for this patient because it can precipitate a stroke. So it has to be gradual lowering of the blood pressure. And treatment for this kind of emergencies is CCB like amlodipine or calcium channel blocker plus or minus a ACE inhibitor. Now this is a very important table for your exam and a lot of questions come from here. So there are some particular conditions where we choose a particular antihypertensive. Like for a patient who has got asthma COPD, we don't choose beta blocker because beta blocker can cause bronchoconstriction. So for asthma COPD, beta blocker is not best. Any of the other is okay. Same with constipation, we choose ACE inhibitor because that's better. Calcium channel blocker, diuretics, they can give constipation. For bradycardia, better not to choose beta blocker or calcium channel blocker. Same with cardiac failure, calcium channel blocker, beta blocker, we have to be cautious before we start it. For a cardiac failure like systolic heart failure, ACE inhibitor is best. For diabetes, again, ACE inhibitor is better, calcium channel blocker is better, thiazide diuretics is not better. Same with dyslipidemia, ACE or calcium channel is better. Hyperuricemia, we try to avoid thiazide diuretics. You can choose any other. Peripheral vascular disease, because it is already vasospasm, you can't use beta blocker in this patient. But for this patient, something which causes vasodilation like calcium channel blocker is a very good choice. Same with Raynaud phenomenon, calcium channel blocker is better. Okay, so that comes in exam a lot. So they give you a scenario and then they ask you what is the best choice of antihypertensive for this patient. Okay, so that's all about cardiology, guys. So we have finished most of the topic that is needed. The only thing that we couldn't cover is palpitation, which we normally cover after this 2 weeks free session is over, and we will do it with ECG. Okay, like we will discuss about all those atrial tachycardia, AF, atrial flutter, supraventricular tachycardia. We'll discuss about some emergency medicine like advanced life support and all of those. So that's part of our ECG class. Okay. So that's it for tonight, guys. I hope you enjoyed our session. Any question? What's about the last slide? Murmurs are important. Yes, it is important. They give you questions from murmur. 11th March. Okay, I'll have to have a look. Okay, I think it hasn't been uploaded, right? So I will chase that up with the team. It will be uploaded by tomorrow. The book that we use for cardiomyopathy and valvular heart disease is Kaplan Step to CK, but the important topics are already in the notes, so you don't need anything extra. Yes, the course provided theory will be more than enough. You don't need to read anything else, but definitely I always say that if there is a topic that's important coming in the exam, you should go and read it from RSCGP at least. Okay, that gives you more idea. But we try to cover all the important topics. But yes, it is a good idea to read from the Australian guideline. After the free 2-week session is over, Dr. Faisal, then we will do the ECG class. So most likely at the end of this month. Yes, after every theory class, chapter-wise MCQ bank will be given. But again, that will be after 2 weeks free session. Currently, Dr. Ifat, I think because there is admission of both of our MCQ and clinical batches ongoing, and a lot of students usually join the course. So currently, it's taking at least a week to get the access for any of you. So that's why I'm saying that if you want to start joining this course, start the process immediately, because it takes some time. We have to give and provide everything in your portal. It takes time. So even though our team is working like almost like 24 hours, if they could, they would do that. But still, it is very hard to give access to everyone immediately. So it takes time. I hope you will understand that. But definitely, if you are waiting for more than 5 days, then send us a message or an email so that we can keep an eye on that. Yes, you have a MCQ test for cardiology that's in the portal. It's already there, but don't just appear now. Wait for everything to be finished. For therapeutic guideline, you will have to buy the subscription from them because it is Australian guideline and you can only get it by subscription. The beta blocker, it's not in here, but if you open the JAM in table 86.9 or go to the hypertension chapter, you will get the full slide. And there is nothing to explain in here. It's all about the like which antihypertensive is better in what kind of condition. Like if a patient has got heart block, definitely you're not going to give a beta blocker or calcium channel blocker. Right? Same if a patient has got PVD, because they have vasospasm, normally we would give something which can dilate the vessels. So best will be calcium channel blocker and contraindicated will be beta blocker. So you just need to go through this, memorize these things, that what medication or what antihypertensive is better for what kind of comorbidities. No, you don't need to read any other book, especially for cardiology. Everything is already in the note. So there is nothing extra that you need to read from anywhere. And I think we discussed it, Dr. Imran. You might not have joined our question solve class. So the initial investigation means that what is your first investigation for a patient? Like let's say a patient coming to you with features of heart failure. For a heart failure patient, you would want to do an echocardiogram to confirm the diagnosis. But you would never send the patient to echo before doing a ECG. You would always do a ECG first, right? So that's what they are trying to find out. What is your initial investigation? That will be ECG. And what is your best or diagnostic investigation? That's echo. And how to use portal? And again, we will discuss once we start our orientation class after this 2-week session is over. Not now, okay? And the course notes will be on course note, mock exams, everything will be there until you pass the exam. So we always give access even after the finishing of the course. The video recordings will be for total 10 months. Yes, so anyone who make the payment, we usually put you in a Facebook course group, so different group, and in that group we give all the Zoom IDs for the class. So you will get it over there. Yes, all the lectures are available in the portal. What about in idiopathic hypertension? Same, management is same. Most of the patients are idiopathic hypertensive, so your management will be the same step. You don't need to buy therapeutic guideline subscription. It is not needed. Ideally, I would suggest to go through the note, read the important things. As you can see, when I am discussing things, I am actually just discussing the important things, not everything, right? So you all also need to just memorize those stuffs. No, so Dr. Kane, we are meaning that everything on the notes. So the notes that we are following, that's more than enough for your cardiology preparation. If there is anything that's needed to be read from JM, we always ask you in the class. So just read this from JM. So we will advise you accordingly. Okay. And to join the course, what you need to do is to contact, either you can contact me through my Facebook, or you can also just send an email. So if you know how to do that, so let me show you. So if you're a member of First Aid AMC MCQ group, and you go to the featured section of this group, you'll see all of our course details in here. So any of you who are looking for the detail or any questions about the course, you can easily go through this thing, and that will answer most of your queries. And you can also get our email ID from here. So it's firstaidamc4536@outlook.com, and definitely you can send an email. Someone will answer your queries, and also you can get invoice from that. Yes, the Facebook page has been already made, Dr. Divya. So if any of you made the payment and you are not part of the Facebook course group yet, definitely send me a message in my inbox. Okay. And yes, notes are provided in the portal. All right, everyone. So we will finish it here tonight. You have a class tomorrow, so that will be taken by Dr. Rabia. So have a look, enjoy the session. It will be a difficult session because it's just a random question discussion. But again, in our question solve classes, we don't discuss theory. So please be aware of that. The theory of those questions will be discussed by me later on. So only thing that you need to learn from this question solve is how we are coming into a conclusion and just a bit of idea about that topic. Okay. Thanks everyone. Have a good night. Take care.